Hello and welcome to this webinar talking about bowel management after spinal cord injury. We are very pleased to have a distinguished panel with you today to talk both about living with spinal cord injury and neurogenic bowel and the practicalities, the basics of the physiology and managing it. We hope that you will also join in the conversation by adding questions to the Q&A section. Sorry. This webinar is presented by the Michigan Spinal Cord Injury Model Systems, which is funded through the National Institute on Disability, Independent Living, and Rehabilitation Research, and the Administration on Community Living. The Michigan Spinal Cord Injury Model System is a collaboration between the University of Michigan and Mary Free Bed Rehabilitation Hospital. Today's event is being recorded, and this recording will be posted to the CDHW website in the upcoming weeks. Our ASL interpreters are spotlighted and closed captioning is available. All attendees will be muted. If you would like to talk rather than just putting a question in the chat, please raise your hand. And definitely at the end of the presentation, but possibly throughout, we will let you speak up and ask your questions themselves. Once again, for our presenters, it is important that you speak up, speak clearly, and speak at a reasonable pace so that our ASL interpreters and the captions are able to capture what you say. Once again, there is an evaluation survey that will be sent after this symposium, and this information is important for us to get an idea of what works and what doesn't, the feedback, the time, and all the other great information. In today's webinar, we'll be starting with the welcome and introduction, then moving on to personal stories and case examples by our lived experience experts, going on to the basics and practicalities of bowel management, and then back to tips and tricks on living with neurogenic bowel and bladder. Finally, we'll go on to a specific question and answer sessions, and then the closing. However, anytime you do have a question, please put it in that section, and we will do our best to integrate it into the programming. With that, I'm very pleased to introduce you to today's panelists. We will be starting with Dr. Rodriguez. Dr. Gianna Rodriguez is a clinical professor and the director of the SCI program in the Department of Physical Medicine and Rehabilitation here at the University of Michigan and Michigan Medicine. She is the co-PI of the Michigan Spinal Cord Injury Model System and a leading contributor to PVA bowel management guidelines. Dr. Jonathan Vandenberg is also a principal investigator for the Michigan Spinal Cord Injury Model Systems and an attending physician for the Mary Free Bed, not the Marty Free Bed, Rehabilitation Hospital. My name is Dr. Michelle Mead, and I am PI of the Michigan Spinal Cord Injury Model Systems, as well as a professor in the departments of Physical Medicine and Rehabilitation and Family Medicine here at the University of Michigan, and director of the University of Michigan Center for Disability Health and Wellness. Mr. Matt Nadella is one of our SCI lived experience consultants, a veteran, and an individual who has been living with complete paraplegia, and he'll correct me if I'm wrong, for about 20 years. And Mr. Carl Werner is also one of our distinguished lived experience consultants and individual who has been living with incomplete tetraplegia for 34 years. And with that, I'm going to let Matt go on to tell you about his story and his experience in living with spinal cord injury and adapting to having a neurogenic bowel. Matt?
Yeah. Hello, everyone. I'm 20 years post-injury after ATV accident, and up until I'd say about 20 years ago, I managed my bowels with technique, digital stimulation, suppositories. I was able to do it independently, which was very important to me, and it was something I just kind of sought out myself on how to do. And then about 5 years ago, I think it was age caught up to me, and pain meds and laxatives and stuff like that just did me in. So I finally ended up getting a colostomy. It was just about a year ago, and I'm currently working on that, getting the colostomy in order. And I don't know, did you need anything else, Michelle?
Just when you were learning about your spinal cord injury, if you can remember 20 years ago,
Like
and
when I was first discharged?
right, what was that like trying to figure out the bowel management? What were some of the key issues that came up for
it
you?
was it was actually I don't know if it's unique, but for me, I was moving into a home that was being made accessible. So for me, the biggest thing was finding a toilet that I could transfer onto. And I'm very hands-on-y, so I kind of did all that. That was real important to me to make sure that the bathroom was laid out just so I could do my ball program independently. That was like the biggest thing when I was first discharged. I wanted to be able to do it independently. I didn't want to have anyone else helping me do it.
And did it work the way you expected it to, or were taught in patient?
There were bad times and good times. No, for the most part, everything worked out well for me.
Right. And what do you think were some of the things that changed along the way?
Age and pain meds, and the pain meds were the final straw for me. I think I started to have to take more and more pain meds for my back, and that was kind of related to bad posture, which was related to inactivity, which was related to bowel program. So everything tied in together.
And then you said that right now you're dealing with a colostomy, right?
Correct, correct.
And are you okay in the management of that, or does that also something
Well,
you're
I,
figuring
I,
out?
I think you remember like a month ago when we talked, I was at the VA in Chicago. We're working on changing up some of the meds, and I'd say about the past week, things have just started to come online, so to speak.
Okay. So it's
Knocking on wood.
okay. It's been a journey for you, and
Absolutely.
so you'll definitely have questions and things that you may pick up as you listen to our two physicians uh, present. Great. Carl, can you share some of your story?
Sure. I'm 34 years now since my initial injury, and I was, as you stated, quadriplegic. In fact, I could not move at all at the initial first couple of months, and slowly but surely redeveloped the ability to stand up and walk, and slowly then afterwards, my arms and hands came back online. Um, so I didn't really sever my spinal cord. It was just bruised badly and swelled up really big. And then I guess when the swelling went down, a lot of my functionality returned. My initial uh, response to everything was, just kind of comprehending all that was going on for me and trying to figure out what things I did need to pay attention to and not. Prior to the injury, I just used the bathroom when I needed to and never thought about any kind of record of what was happening or how the stools looked or anything. I've since had to learn how to do all of that. And, the first 20 years, I'd say, were relatively normal. Um, the pain meds caused me more issues with constipation. And so I was constantly having battles with that. And as I've gotten older, they've slowed down a lot. So in addition to the constipation, we've been trying to work on the frequency and trying to get at least 3 or more bowel movements per week. Um, so what I find now is that I'm paying so much more attention to it, sort of tracking and keeping a record of when I actually use the bathroom and what time and what things are going on leading up to that particular, series of bowel movements and what I'm eating. All that comes into play now, and so it's a just a big analytical thing that I'm working on all the time, trying to get it into stay in some kind of rhythm.
Okay, so here we have two individuals, both living and aging with spinal cord injury for over 20 years, who have gotten to different points with their bowel management program, who've had different impacts on them, whether ambulating and physical activity or diet or medications. And so as we listen to Dr. Vandenberg and Dr. Rodriguez, we're going to be very much interested in how we're supposed to think about this, how to communicate with the physician, what to expect initially, and how things change. I think often folks learn about what to do with their bowels when they're in the rehab, but things can change a lot. And so what to expect and where to start, I think, is always a big question. So with that, I'm going to turn it over to Dr. Vandenberg, who will start us off.
Hi, thanks, Michelle. So I'm just going to start by sharing some of my slides. Okay, perfect. So first, I just want to start off with a introduction about neurogenic bowel. I see people with bowel issues all day long, almost every day of my working day, and it's a very common problem after spinal cord injuries. And people can have a variety of ways that they empty their bowels, but everybody's different. And so everybody responds to medications, everybody responds to physical interventions like bowel stimulation or colostomy or sitting up on a chair differently. And so I'm going to talk a little bit how I try and empower people through knowledge of their basic anatomy and kind of what's going on after a spinal cord injury. So first, one question I get asked all the time is, well, if I'm injured at this level, what does that mean for my bowels? And so what I will oftentimes tell people is the higher level that you're injured, the more reflexes are likely intact. And so the more responsive you are to some of the bowel program, like say your digital stimulation um, or suppositories or other treatments. So if I have, and can you guys see my mouse as well?
No.
Oh,
No.
He's on the spinal cord on the
Okay.
left, right?
oh, okay.
Yes, yes, exactly. So for your levels down to around T10, T12, people oftentimes have what's called a reflexic bowel, where they will have reflexes. That's not for everybody, but that's just kind of a pattern that we anticipate.
And I'm
For
sorry,
lower level,
by reflexes, do you mean that it happens like prior to the spinal cord injury or prior to the neurogenic?
yeah, so people have reflexes inherently. And so they will have reflexes before their spinal cord injury, but we try and use those reflexes to get people on a bowel program after their spinal cord injury because they tend to have less control. And so for lower level injuries, like below the T10 to T12 level, they will often not have those reflexes and they'll have more of a kind of loose bowel. program. So their bowels won't necessarily squeeze or hold things in as well. And so we'll have to keep things a little bit more firm and then try and pull things out. So in terms of keeping things firm or keeping things soft, we typically look at this stool chart. It's called the Bristol Stool Scale. And we aim for type 4 or type 5 for most people. That will hopefully keep things in without getting things too loose like peanut butter, where the colon can't push things through, or too hard like deer pellets or sausage like with cracks, where it won't move through properly either. And then too loose is watery or liquid. Okay, so you may hear people refer to like peanut butter like stool or deer pellet like stool, and that's one of the ways that we describe things. And I don't know about anybody else, but I always look at my poop every time I go, and that will help your doctor figure out what is going on with your bowels. If you look at your poop and tell them how much is coming out, when it's coming out, creating a bowel diary. In terms of where in the spinal cord you're injured, if you have a complete spinal cord injury, that's a little bit more predictable than an incomplete. For people with a lot of movement in their legs and their arms, they're probably going to be able to go more voluntarily. They're probably going to be able to control more. But as I said, everyone's a little bit different. If you have a more complete spinal cord injury and you have trouble moving your legs or you have trouble moving your arms and your legs, things are going to be a little bit more challenging because you don't have as much control of your bowels. And so that's when we get into more of the bowel programs that Dr. Rodriguez is going to talk about. This picture over on the right is a picture of that lower spinal cord. And so this is at the L1 to L2 level typically. And if that, what we call conus medullaris, or the very bottom of the spinal cord, is injured, that's where a lot of your reflexes, or how we try and treat the injury, are gone. And so then you won't get as much of a response from, say, a suppository or digital stimulation, and we'll rely more on that manual disimpaction. But we'll talk more about that in the later slides. Just some common issues that happen after spinal cord injury. For cervical spinal cord injury or a neck injury, people oftentimes have dysphagia, especially early on after the injury, and 41% approximately. Also, for a neck injury, people can have decreased stomach movement, and that's called gastroparesis. And so we do have some treatments for that as well. That can cause people to feel more nauseous, or just like things aren't moving through. Decreased appetite are common signs of that. Abnormal gallbladder motility. So your gallbladder is part of your bowels down in your belly, and people don't have as much movement there, so they can get more gallstones and things like that. The liver circulation isn't quite as good as well for T7 to T10 and above, and so your blood vessels just aren't quite as responsive for levels above that T6. In terms of acutely, people oftentimes lose a lot of their reflexes acutely. So that means like when they're initially in the hospital and soon after their hospital, like when they're going into rehab, and they oftentimes, it's a moving target. And so your bowels kind of lose all the reflexes, and then they'll gradually come back over months after your injury. And so over the first 6 months, if we get people under control, we're doing pretty well. But I always try and set expectations early on. This is a hard problem to solve because of all the moving targets. People are on pain medications like Matt described. People are taking a lot of different muscle relaxers. They're oftentimes changing what they eat because they're in the hospital. And so all these things can have an effect on how you move your bowels. Sometimes they're on antibiotics too, which can also affect things. In terms of reflexic or areflexic bowel, that's kind of what I was talking about, and what I'm sure Dr. Rodriguez will get into a little bit more. Also, I always tell people when you're taking your stool softeners, you want to look like 2 to 3 days down the road, because things slow down in terms of your GI system. And so I call it the beet test. You eat a beet, how long does it take the beet to come out the other end? It's probably going to take about 2 to 3 days. And And so this is shown in the papers that things are going to just take longer to get through your system. So if you take a stool softener one day, it might not soften your stool for another couple days, and you don't want to yo-yo back and forth. So in terms of how your autonomic nervous system, and that basically means how your brain and your spinal cord interact with your gut, it's not a complete control. So back in World War I, they strung up some intestines of a mouse and they blew into it with a straw. And these were completely separated from the brain and the spinal cord. And what they realized is those intestines blew back. And you wonder, well, if it's connected from the brain and the spinal cord, how does it blow back? And that's because of the enteric nervous system. And the enteric nervous system has a mind of its own. When people say, oh, go with your gut actually has a lot of neurons that are working on controlling that system. So your brain and your spinal cord do have some input into the system. And so I look at it two ways. The parasympathetics, which is your rest and digest, and that's what moves things through, and then your sympathetics, which is your fight or flight. So if you're running from a bear and your fight or flight, do you want to poop or don't you want to poop? You probably don't want to poop. The bear could track you. Okay. So the rest and digest system is if you're not running from a bear, that's what makes you want to poop. And that's what increases the colon pushing things through. That's what stimulates the secretion. So bringing more fluid into the bowel and making sure things are lubricated. And that also helps relax the sphincter so that you can empty completely. The sympathetics are going to inhibit all that. They're going to slow things down. They're going to decrease the secretions, kind of dry you up. And so we have different ways of trying to affect these two systems. But a common reason why people get constipated when they fly is because it's a little bit nerve-wracking flying, and that ramps up your fight or flight system. Another thing is if you have a lot of what we call autonomic dysreflexia, and for those of you who have that, you probably know what it is. But it basically increases your blood pressure, ramps up the sympathetic system. That can also cause more constipation. So this is just kind of an outline about how things are innervated, or where the nerves go to from your spinal cord to the colon. So for people wondering about reflexes, that's down here in the lower part of the spinal cord for S2 to S4, and that goes to this distal third of your colon. And then the top of your colon is actually coming from the vagus nerve, so that's coming from higher up, typically above people's spinal cord injury. So this is the enteric nervous system. This is the bowels, and they have a mind of their own, and they're actually able to push that stool through independent of the central nervous system or the brain and the spinal cord. And you have two different plexuses, the Auerbach's plexus, which is affected by certain medications, and the submucosal plexus is more in charge of secretions and absorption as well. So normally the colonic contractions, or the colon, pushes things through. That goes down into the rectal vault, which is the end of the colon near the rectum, and that stretches a few of the muscles in your pelvic floor, or close to your taint or your perineum. Okay, and that stretching causes a holding reflex that holds things in. If you don't have that reflex, it's harder to hold things in, which is why those areflexic, or the lower level injuries, have a harder time holding things in, and they can sometimes leak. So sometimes it can be good to have those reflexes intact and be a higher level injury, because that may make it easier to hold things in. Then people will try and relax and have a bowel movement by relaxing that sphincter, and abdominal musculature kind of pushes that stool out, helps push that stool out, along with the rectal vault squeezing it out. So in spinal cord injury, we use these reflexes to try and optimize your bowel program. So the gastrocolic reflex is when you stretch the stomach, and that sends signals to your colon to move things around. Okay, that happens in about 30 minutes. So you eat something, about 30 minutes later, you expect things to be moving. The colocolic is when we bulk stool so that it stretches the colon and helps move things through. And that will open up where the stool is going and squeeze where the stool is. So it pushes it forward. The rectocolic is what we use all the time with people with reflexic bowel. That's the higher level injuries. And that's where we put a suppository in the rectum, and that stimulates the area and signals up to the colon to move things around. The other way we do that is with digital stimulation. And I'm sure Dr. Rodriguez could talk about that more, but I like to talk about one of the guys.
Dr. Vandenberg, just a quick question. How does aging impact that part of the system? Does it impact the timing or certain sympathetic or parasympathetic or any of these other systems that you use?
Yeah, sure. So aging can definitely cause differences. One of the biggest differences is I find the reflexes can wear out, especially after a lifetime of using um, suppositories, enemies, or digital stimulation. People just become less responsive, especially if they've gone through life with more chronic constipation and stretching of the colon. The colon tends to not push as well. And that can lead people to search out other treatments like colostomy, because they're not emptying completely. Um, but um, but yeah, aging can definitely affect the body in multiple ways, but it's oftentimes a result of using those reflexes uh, chronically throughout their life.
Thank you.
I do just want to give a shout out to one of our nurse techs here at Murray Free Bed. He is a wonderful man, and one of the many pieces of advice he gave me early on was bowel programs more than just about doing digital stimulation. It's about connecting with that person to help them understand that this is a normal part of spinal cord injury, and making them feel comfortable and connecting with them as a person. And he is amazing at getting people to relax, because if people aren't relaxed, they won't have a good bowel movement, partly because of that fight or flight response, likely. But Troy is known as the guru of poo, the sultan of scat, the #1 man in the #2 business, the Prince of Pooh. I have multiple others. They're on my notes, but he really teaches people how to do these bowel programs, and helps people become comfortable with completely evacuating, because that's going to prevent accidents in the future. And so again, that's utilizing the reflexes to help people empty completely. If they don't have the reflexes, then we go about it by other means. But I think that's a good transition to management. So I'll pass things on to Dr. Rodriguez. First, I guess I can take some questions if you'd like.
Sure. There are a couple of questions I know in the chat. The first, do suppositories cause hemorrhoids?
So the act of digital stimulation and suppositories definitely have their positives and their negatives. Digital stimulation can cause hemorrhoids. But that's why we don't do it too aggressively. It's gentle stimulation with one finger, not more than one finger, and for 15 to 20 seconds, and then you wait 10 to 15 minutes. Typically, we recommend up to the first knuckle for people with different body habitus or amounts of soft tissue down there. Sometimes you have to go a little bit farther, but again, that's individualized and should be taught by a knowledgeable person.
Okay. And then the second question, the 72 years of neurogenic bowel and bladder cause damage to your organs?
Say that again.
Does living with neurogenic bowel and bladder for 62 years cause damage to the organs?
Yes, it causes changes. So living with neurogenic bladder can cause multiple issues with the bladder, thickening of the wall, contracture, shrinking of the bladder. Could also lead to potentially kidney damage if not managed appropriately, or even if managed appropriately, but just kind of the natural course of the disease. In terms of bowel,
Mhm.
chronic constipation is also is oftentimes a complication because people would rather be constipated than have accidents. And so that can lead to stretching of the colon, which can lead to issues with that colon pushing things through, bowel obstruction, diverticulosis, which is like little outpouchings within the colon. And so we do try and avoid that chronic constipation. Also, just in general, avoiding accidents can help prevent skin damage and that sort of complication too.
Okay, thank you. We have a question from Darius. Darius, if you wanted to get online, we've unmuted you, and if you can share what your question is.
Good afternoon, Dr. Vanderberg and everyone. Thank you. Allow me to ask, I am a C6, C7 complete quad post-injury, 20 years post, and I've been using digital stimulation since then. And currently I have two caregivers. I have, all of them have been with me since the accident until now. However, they're getting older. One of them has small fingers and one of them has large fingers. And the one with the larger finger is always causing me autonomic dysreflexia every time he does or she does digital stimulation. Now, I recently aging also caught up to me, and I've been having severe bloating because also pain medications, antibiotics. Up to which point should I consider colostomy? Because recently I've been having severe bloating nonstop despite of Movantic for opioids, pain medications, despite increasing fluids, despite enemas, despite stool softeners and so forth. Seems like things now are not working and I'm getting bloating almost 24/7 and sudden change of bowel habits too, from constipation and then at the end of the bowel program, it is liquid. So
Yeah.
up to which point should I think that I should now consider colostomy?
Yeah, it sounds like you've gone through a number of different trials for treatment. But my first recommendation would be definitely consult with your individual physician. These are such customized decisions that they're really hard to make in a short, brief overview. However, I will say I do have a lot of severe quadriplegia who decide that colostomy is best for them. And that's oftentimes after some thought or some difficulty with a regular bowel program, using suppositories or using a variety of the other enemas, transanal irrigation, which is considered last line before colostomy, and that includes like the Peristine system or the Navina system that kind of flush the entire colon. It's almost like a colonic. And so oftentimes people want to empty through their rectum first. Okay. However, in quadriplegia, I oftentimes hear guys tell me after they've gotten the colostomy, that's one of the better decisions I've made. It increases independence. It allows you to go about your day without doing an hour-long bowel program. Oftentimes, it can avoid dysreflexia in certain people. However, they're not without their risks. And so I think this sitting down with your individual physician and talking through all those risks and trying to decide whether you have tried those other options that I mentioned, or if those would be right for you, is I think the best course. But I know Dr. Rodriguez is going to jump in here with a bunch of evaluation and management discussions, and so I think
I
that'd
was
be a
going to
perfect
say,
transition.
transition to Dr. Rodriguez and some of her overview about bowel management. And I'm sure
Thank
we'll
you.
have more time to talk about colostomies and the when and why later. So
Thank
Dr.
you, Dr.
Rodriguez.
Vanderberg.
And thank you for sharing, Darius.
Thank you, Dr. Vanderberg, for setting this up, for setting my portion up to talk about. So, Dr. Vanderberg actually went over, some of the differences in management programs for reflexic and areflexic neurogenic bowel dysfunction. And, my portion will talk about how we can personalize management for different folks, depending on their injury and, history, etc. And then how we can implement management based on indications, and how we can use various strategies to help regulate bowels. So it's helpful to think about management of neurogenic bowels in two categories. So we know that motility is slowed down throughout the colon, and we have about 5 feet of colon that the stool has to transverse, before it gets to the rectum. And you can think about the rectum as a pouch where, your stool is stored before you need to empty. So in other words, that stool has to make it to the rectum first before you're able to empty things, right? And the second category of dysfunction is where the stool needs to be emptied through the sphincter, from the rectum through the sphincters, and with the help of the pelvic floor. So normally it's a really good coordinated defecation function where your rectum is filled, the person is able the person has the urge, and the person is able to voluntarily relax the external sphincter and control the pelvic floor muscles so that the rectum is emptied of stool. And also a good thing to remember is as the stool goes through the colon is constantly trying to absorb water from that stool mass that's going through the colon. So the longer the stool stays in the colon, the harder it gets, okay? So we know that sensation is diminished, there's poor or no urge, and people may have a vague abdominal discomfort with rectal or colonic distension. And we know that muscles of continence are impaired. And a lot of times for people who are having fecal incontinence, I'm not saying all the time, but a lot of times when one has fecal incontinence, it's actually an indication that they're constipated. So, when somebody has fecal incontinence and they say, oh, my stools are a little bit more watery, 95% of the time people are constipated. So it's more like an overflowing incontinence because the stool has stayed in the colon for a long period of time. And the new stool that's going around the old stool is watery and is what's causing the fecal incontinence. So I mentioned we have abnormalities in our internal and external anal sphincters and our pelvic floor. So the GI history determines approach to treatment, okay? And your provider will ask you a lot about, these various, so we'll have various questions about frequency of defecation, stool consistency, volume of stool, time of day, duration of bowel movement, because this also helps us with trying to manage the bowels as best as possible so that it's timed, scheduled, controlled, and regular, okay? And these are the other questions that we ask, obviously, if people have abdominal pain and discomfort, and if they're able to control the passage of stool some, if there's some sort of urge or urgency, and if, let's say, they are incontinent, if there's some sort of awareness that they are incontinent. And then we ask about what medications have been used, both oral and rectal wise. Because a lot of times, one medication or the other has been used and then people are like, well, it's not effective, but really it hasn't been used to its maximum or maximized levels. And then also perhaps the schedule of the medications and methods were just not as proficient or efficient, and we can again optimize that. And then strategies to initiate defecation and bowel emptying. There's a number of ways, and trying to coordinate both medications and strategies are important, or is important. And then we would like to make sure that the duration of the bowel emptying is reasonable. I have some patients sitting in the toilet for 3 hours, and it's definitely not what we recommend. And then perhaps positioning is always best, in the squatted or the seated position rather than in the laying position. And obviously, some of that is also affected by the need for assistance. And again, this determines the approach to treatment. And we asked about, past GI issues, if there were, and then all the different medications used. And a lot of these medications that, our patients with spinal cord injury use are very constipating. And some of them we can get away from, but some of them we can't. And then important to hit the basics, such as like good diet with good natural fibers and sufficient fluid intake. And obviously, the more active and mobile the patient is and upright, the better the outcomes for the bowels. So hitting the basics, okay. I think it's always good. I always repeat this to patients. We need to satisfy the goals. Okay, we need daily or at least every other day sufficient regular bowel movements. Okay, and then timing and making it consistent. Doing the bowel program consistently in a chosen time of day, whether it be morning or evening, helps us actually time when bowel medications are taken orally and when strategies are implemented for bowel emptying. Officially, constipation is defined as less than 3 good bowel movements per week. So when we say good and adequate, that means at least 2 cups of stool. And, this is anecdotal, but, sufficient enough. So moderate to large outputs, at least daily or every other day. And of course, if it's every other day, then more than that. And then we don't want any incontinence, so we don't have wounds. And soft bed form, as Dr. Vandenberg stated, Bristol stool type 4 to 5. And we would like to keep the bowel care or the bowel program to at least less than an hour. And then having folks sort of follow or know what their patterns are and log all these is important. So, if you're having trouble trying to figure out what to do, you can always present the log to your provider and they can help with problem solving. Like I said, it's very important to maintain good nutrition with good intake of natural vegetables and fruits, and good sufficient intake. And there it is, at least 2 liters of fluids, non-caffeinated, emphasis on the non-caffeinated per day is best. So in terms of strategies, okay, so again, when we think about moving stool through the colon, okay, you have 2 kinds of oral medications. You have what you call the stimulants, and I'll give you a list of stimulants, and you also have the absorbents or the osmotics. So the stimulants sort of zap your colon to start moving, okay? And the osmotics are the medications that add water to your stool to help the colon move your stool more sufficiently and efficiently, okay? Your rectal medications help time your bowel movements, and it also helps initiate your bowel movements, and it helps complete your emptying of your stool. So it triggers your defecation, it times it, schedules it, and it makes it expected for the patients to empty during specific times of the day. And again, the more consistent you are, the more you habituate your system to do this. And a combination of these oral and rectal medications or strategies is important, and we need to find what works for folks. So this is just a good summary of what these stimulants and osmotic laxatives are. And, you know, sometimes we do use supplemental fiber to help with the consistency of stools if we have to, right? And these are the newer agents or the higher level bowel medications that do help move stool through your colon. And then for stool evacuation, again, we have, you know, as mentioned by Dr. Vandenberg, is digital rectal stimulation is the simplest, all right? We use our reflexes to help move, so trigger a reflex so that we have good rectal emptying. It also relaxes the sphincters for those who have tight sphincters to help eliminate stool. Okay. But we have to monitor for autonomic dysreflexia while we're doing digital rectal stimulation. You know, it can be done side lying, but it's preferred to be done in a padded commode upright. And then just like digital rectal stimulation, you can use suppositories, enemas, and transanal irrigation to augment your digital rectal stimulation if digital rectal stimulation is not sufficient. So you have, you know, the various suppositories. So, you know, the best ones that work are actually your vesicoidal suppository, your magic bullet suppository, where you have, you know, it's polyethylene glycol based, so it works better than the vegetable oil based vesicoidal suppositories. And again, this is called the magic bullet suppository. And then the docusate mini enemas, or what you call the enemies mini enemas, also help. You know, a lot of times I'll go with the magic bullet first and then go with the enemies, you know, because enemies is more expensive, and that's the only reason why, and not covered by insurance. So, you know, again, all these agents help with timing the bowel movement, emptying, triggering defecation. So this is just some photos of what they are. And then if, you know, again, you can add on, if not instead of, use some enemas. And I typically use this enemas with milk and molasses or soap suds, or mainly to clean folks out when they're severely constipated. Everyday normal saline enemas can also be used for regular bowel program. Okay. And then you also have, as mentioned by Dr. Vandenberg, your transanal irrigation, where you have higher level devices that can help with emptying the rectum and actually the final portion of your colon, which is your sigmoid colon, for more sufficient emptying of stool of your colon. And, you know, typically this is used for those who have insufficient results with your basic bowel management or program. And there is evidence in our literature that it does show to improve constipation. It reduces what patients take in terms of medications, and it improves quality of life overall. And then the most common surgical intervention to manage neurogenic bowels is your colostomy. Essentially, it's a stoma that's created in your left lower quadrant, and typically, you know, they do it towards the end of your colon because this is where your stools are most formed. They try not to do it more proximally, because the more proximal you go in your intestine, the more watery your stools are. But, you know, in the literature, it also does show that people who have colostomies have superior quality of life outcomes, and because it decreases time on bowel care, it decreases hospital administrations, hospitalizations for significant fecal impaction or obstruction, and it makes it a little easier to manage the bowels. So that in a nutshell, I know I tried to go over that pretty quickly, but in a nutshell, that's how we sort of like approach bowel management. I am now open for some questions. I know we don't have a whole lot of time.
Actually, we have till 6:30, so we're good.
Oh, perfect.
Okay,
All right,
so let's
cool.
go back, if we could, to the colostomy. Can you say a little bit about why, when you said that you try that when other treatments fail, what are some of the downsides, or why isn't it done immediately?
So, it is a surgical procedure, number one, and it's a major surgical procedure where people have to undergo general anesthesia and things like that. So if the basic bowel management works and, folks are not necessarily having major issues and things are pretty regular. I mean, and if the goals of the bowel program are satisfied with the basic bowel management, at that point, there is no need necessarily to pursue, a colostomy. So, when people start to have more problems with, trying to empty regularly, and they start getting constipated, weeks at a time, or if they start having significant abdominal pain that's related to recurrent constipation, or if they've had bowel obstructions, then, and, if they're having such difficulty with emptying, or they have wounds, or they have recurrent fecal incontinence, and it's just getting harder to manage their bowels and they're in constant pain, then this is where the colostomy sort of like is brought up. Or if we're using a ton of medications, both oral and rectal wise, or ton of medications orally, and then we're doing everything, transanal irrigation, use of suppositories, etc., and still nothing is moving, then that's where we say, okay, it's time to talk about a colostomy.
And how does having that stoma and external bag impact activities? Do you have to limit what you do, swimming, showering, other types of movement?
So, swimming in the sea or, open water is not an issue. I think it's mostly swimming in, in private pool, I mean, or commercial pools, obviously, where if the bag comes off, then there's risk of contaminating the whole pool, right? So that's the only issue with regards to being in a body of water. So if it's, open water, the sea, or, lake, then there's no issue with getting into the water. It shouldn't matter, you can shower. Obviously soaking in a tub might be tricky, because anytime you wet the appliance for the colostomy, it can sort of like start having the wafer come off if it gets too wet.
And is there an increased risk of infection through that area?
No.
Right. And how is there a time that you can live with a colostomy? I know a lot of times folks have been saying that they consider a colostomy after 20, 30 years, but is there any research about the
There's
amount of
really
time?
no timelines. I think people can live, many, 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 many years. And actually, I think at least from the literature out there, and from my own experience with my patients, for people who've had colostomies, it actually does facilitate the movement of stool through the colon a little bit better overall. So you remove one component. I talked about two categories of impairment. It's moving of stool through the colon, so motility, and emptying. So you facilitate the emptying through the bag. So it makes it easier for the body to, to move stool altogether, and you're not having to deal with the the sphincters and the pelvic floor and things like that. And when you remove that issue, the movement through the colon is better facilitated, because when you have issues with emptying, that's what you call a functional obstruction. And so you remove that functional obstruction piece. And when you do that, you're able to move things through the colon more sufficiently. I think Matt, Matt has experience with the colostomy, can probably give you his input on, how things have been for him with a colostomy.
Yeah,
Matt?
absolutely. What Dr. Rodriguez and Dr. Vanderberg talked about, that's basically what I went through the whole course of it. They they described me to a T, pretty much. Tried everything, and then just recently ended up getting the colostomy done. And like I've heard from, I'd say 4 out of 5 people with the spinal cord injury, 20 years post injury, that's when they do it. And so here I am.
Yeah, and I think
well, as far as wearing the bag, I think that's what you asked. I haven't had as many issues as I thought I would. The only issues that I had is when I did something real dumb, like got it wet or something like that. But I think for the most part, I'm still trying to regulate things like my diet to get everything working correctly. But I'm happy with it. I'm happy I did it. I can eat more, which is nice. Before, I'd have to limit my diet to certain things with just doing the either the Parastine or just the regular DigStim that I did for, I'd say, probably 15 years. I can eat more. I don't have to watch out for as many foods. So that's been another benefit, certainly.
yeah. So I don't necessarily wait. I there is a readiness for people as well to talk about the colostomy. A lot of times and there's not necessarily in literature now, it's actually encouraged to bring it up a little sooner, because it does help facilitate, movement of stool and emptying of stool. And so, with regards to what Matt said in terms of eating, sufficiently or without fear, for one, and, eliminating the abdominal discomfort from constipation, etc. Fear of leaving the home is another one. Altogether, I think I tend to bring it up sooner too, but there is a readiness. I kind of try and feel the patient out with regards to, bringing up the topic on colostomies, because some people are like, no, it's
That was me. That was me.
yes,
So-
yes.
Even before that, what if we go back to the relationship? Because I think, that's one of the things I heard from Dr. Vandenberg, and one of the things that you're feeling the person out. What you seem to be implying is that you have a long-term relationship with someone, and you've worked with them. They are able to provide data on what works and what doesn't, and you're able to make those personalized and tailored adjustments. Is that accurate?
Yes, I totally agree. I think the bowels are much more of an art than a science for people. People respond to medications in different ways. And so we can try and have errors, but people learn from those experiences through time. And we make these decisions on an individualized basis. Different things can push us towards colostomy, like wounds. When people soil their wounds from bowel movements, say pressure injuries on their butt, then those won't heal very well. And so that can push people towards a colostomy. Sexuality, having bowel accidents can turn people off. And so having a more managed program can be more desirable for some people. There's lots of different factors that kind of go into making those decisions. But as I said before, they're not limited to tetraplegia or people who have trouble with their arms. I have guys who have lower level injuries who are walking, and really their primary issue is they can't control their bowels and their bladder because those S2 to S4 levels were damaged. And for those people, they tell me, you know, doc, I haven't left my house in 20 years because I'm afraid of having bowel accidents. You say, well, have you thought about this? So.
Okay. And would be even before that, when folks, well, first of all, what type of provider, what type of physician do you need to begin to really work on bowel management issues? Do you need a spinal cord injury specialist? Are there other people who are certified or have this type of training to partner with you?
I think I think the spinal cord specialist, obviously, I think is the most knowledgeable because they know about neurogenic bowels more. And I know, I know there's initiative to try and educate. And, I've done this myself at Michigan Medicine, partnered with GI, we're part of Michigan Bowel Control Program, and trying to have the other specialists or providers understand what neurogenic bowel is and how to approach this and manage this. So, and I like overall nationwide, I think there's this initiative to try and get the spinal cord specialists partnering with the primary care physicians and family medicine practitioners, particularly in the more far-flung areas, so that they're more aware of how to manage, not just neurogenic bowel, but, other sequelae from spinal cord injury.
Totally. I also think engaging the occupational therapist, the nurse techs on the spinal cord floor, but also in home health can be really valuable. We typically bring people in for training during their inpatient rehab stays for education, and then we do training on the outpatient clinic with our clinical nurses who are very well versed in bowel programs to do education over the phone and troubleshooting to help people with their bowel programs. And I know the Navina system does a nice job with their clinical nurses educating people on how to use the Navina system and transanal irrigation. And so there's a lot of knowledge, especially in the spinal cord injury subspecialty. But yeah, I think making those collaborations with GI, because they're the people that do the colonoscopies, and going through that is a whole nother lecture probably.
And also, I think, like from seeing patients, it's education. I mean, I think we educate them during the inpatient rehab stay. I think people change and, life circumstances change, people adjust, change, whatever they're eating, drinking, whatnot. And, there's constant change. And so with that said, it's reviewing with folks. Okay, these are your goals. Okay, let's go over what you've done, what you've not done. Let's optimize your bowel regimen, your bowel program. We can try a combination of this, that, whatnot. And again, sticking to the goals and sort of like trying to do, and I always tell folks who are having a little bit of trouble, we need combination. One thing will not necessarily work on its own. And if a combination works, then let's try the combination.
I think that's what I'm hearing, that bowel management, as John said, Dr. Vandenberg said, is the art. It's not this is what you do and it's one size fits all. It's very much customized and individualized, and based, what you decide or what will work is going to be based on that conversation. And so you got to feel comfortable, and you have to specifically say, how will we get this information? How will the data to make a decision? How will we use it? What things can we change? What things will we change? And how will this impact both your bowels and your life?
And then one more thing I'd like to say before we go to the next question is, I think trying to get the patients as independent as possible in adjusting their medications based on their outputs, or based on how they're doing altogether is key. Some people are, get it better than others. And yeah, trying to, come up with a good plan and good way to adjust medications if need be, or strategies if need be, so that, they're not constantly having to rely on providers as well to sort of like satisfy what needs to be done.
So you give them an algorithm. If you have too loose,
Yes.
then you do this. If it's too hard, you do this as a first
Yeah.
step
Correct.
before you.
Yeah, I always tell a joke, and I don't mean to make light of it, but if you go home and you eat a big burrito, it's gonna be hard for me to help you, because there's so many moving factors when people go home, and so we really try and empower patients with these medications and teach them how they work, teach them the physiology, so that they can better titrate these meds themselves. Because most of these bowel meds are over the counter; you can just buy them. So.
And
Yeah,
then
that's a great point.
couple of things. I know we have another question from Darius. How you mentioned that it's important to do uncaffeinated. How do things like caffeine or lactose or such impact the bowel or the bowel management program?
Caffeine is, a diuretic, so it pulls away water, so it essentially dehydrates folks. So if you take so much caffeine, then you're dehydrating yourself, and you have to make up for the loss of fluid. And like many different, so Mountain Dew, for people who are taking a lot of Mountain Dew or high caffeinated sodas, etc., to keep that in mind, or tea, even tea, caffeinated tea, one has to be conscious about that. So there's so many different scenarios. If you take too much fiber and you don't drink enough fluids, then you get constipated. So just keeping those things in mind. And I think, people are aware of what gets them into trouble. And, you sort of like cue folks to take note of that. What gets you into trouble? Obviously lactose for is one big thing, as you mentioned, because people do get gassy with lactose drinks. And if they have to stay away from lactose, then, that's an easy fix.
So what I'm hearing is, once again, empowering people to learn their own bodies and really to track and work with their physicians to make, or their clinician to make decisions.
Correct.
Makes sense.
And just on the caffeine thing, I know every time I drink a coffee, I have to poop. So I think there are other chemicals within coffee besides caffeine that can potentially.
And John, can you get a little closer? I can't.
Oh,
go.
sorry.
There you
Yes, I agree with what Gianna said, basically. That's fine.
Let's go back then. Darius, can you you had a question?
Yes, just a follow-up question, Dr. Rodriguez, Dr. Vanderberg, and or Matt. So it has came to a point that I think the indications for a colostomy has trumped, because right now I have a history of wounds, chronic wounds. I have both stage 4s at both right and left ischiums, and also the sacrums. In fact, I'm a wound vac right now.
Wow.
So aside from that, of course, I do digital stimulation laying in bed because I cannot sit, because of the wounds, because of the stage 4 wounds that healed. So because of that history, I'm not able to sit. I do digital stimulations in bed. Now, I also have a urostomy, an ileal conduit on the right side. So my question is, how does having a urostomy affect having a colostomy also? especially that a part of my intestine, small intestines, have already been removed, used an ileal conduit for my urostomy, and now I would like to have a colostomy. It's because my caregivers, they are not telling me yet, but they've been with me for 2 decades, and they're like, Darius, we're planning to retire. So, they don't say it upright because they love me, but it's going there. So I'm planning to have a little bit more, I guess, independence with having a colostomy than digital stimulation compared to yeah. That's my question too.
Good question.
Simple answer for you, Darius. Yes, it's time.
Yeah, get it.
I'll have Dr. Vandenberg weigh in as well, but it is time.
Yeah,
I-
I agree. I mean, it sounds like you have all the indications. And as I said, once people have it in your situation, oftentimes they don't look back.
And is there, though, contraindications with other abdominal surgery or other types
No.
of?
No.
What about the what do you call it for the urination? He said he had that. Isn't that
Yes.
something where you insert the catheter through kind of a stoma?
No,
Yeah,
it's
so he has a bag. He has a passive system.
Okay,
So-
so he doesn't do intermittent cath.
Yeah, but regardless, I mean, it should not prevent the procedure for colostomy.
I was just thinking UTI wise, if they were close together, the stomas, I guess, kind of
Mm-mm.
thing. So
Well,
if-
I know we'll be looking for more questions. I wanted to go back now, if we could, to Carl and Matt to talk some about what of the issues they had, or maybe to bring up some of the things that they learned, or how they learned the management as they've been living and aging with spinal cord injury and neurogenic bowel, and directly ask our physicians here if any of the questions or to clarify anything. Carl? You're on mute, I believe.
Yeah, before we jump to that, I want to talk just a little bit while I have you two here, doctors, about aging and spinal cord injury, because I'm like, my first 20 years were almost normal, and then slowly but surely I've been having these issues with slower and slower bowel movements to the point where we are concerned about it. And trying to treat it has been relatively new for me. I'm in the process of learning. That's why I'm tracking so much of this, what's going on, plus the complication of diabetes. On top of that, has an effect on my appetite and certain things with my diet and what I can and can't eat. So, what I want to talk about is as I slow down with my activity, and of course my bowels slow down, I understand that effect. But the treatments that I'm doing right now are just basically the Miralax, some combination of lactulose and Senna. And most of it is maybe say 6 or so pills of Senna every night, maybe every Monday, Wednesday, and Friday or so, a dose of lactulose, and then Miralax as needed. And it seems to get me, into every 2 to 3 days, but I can't seem to get faster than that.
So Carl, I
Yeah.
know you just saw us, and I know you saw Chelsea.
Yes.
So we can, I can get you scheduled for
Okay.
an
Okay.
appointment.
All
And
right.
we can tease this out,
Okay.
to optimize your bowel regimen.
Okay.
But can you say some general information about
Just-
aging?
Aging.
Yeah.
So normally, in someone without the spinal cord injury, there is some decrease in your intestinal motility. And so older people do get constipated, but you throw And, everything else that happens during aging, like you said, diabetes, diabetes tends to slow down your motility as well. And then, people change their eating habits, their intake of fluids, medications are added on to their profile, and that affects bowels too. So, a lot of things do occur. But what I can say is people who were less optimized in the past are more affected as they age. But like in your case, you said you were good in the past. And, as you're aging, I think, it's easier to manage those who had more regulated bowel movements in the past rather than those who have not, because there are more issues and problems and just general things that need to be considered in patients who've had recurrent constipation, recurrent fecal impactions, etc. John, you're on mute.
Oh, can you hear me now?
Yeah.
Now, yes.
Okay. So, yeah, I mean, things slow down as people age, and you have to gradually escalate your program, just as you've described. Sometimes in terms of my escalations, I'll increase the Senna, just like you said, up to 6 tabs. But if that's not working, maybe I'll go to like an oral bisacodyl medication, which can be a little bit more powerful or just a little bit different for people. Also, lactulose is a good kind of osmotic. It brings things in, but it also creates a fair amount of gas. And so milk of magnesia may be effective too. It does create softer stools, but it also kind of stimulates and pushes things through. And then looking at what you're doing from down below. So if you're doing a suppository, maybe upping it to NMEs. Another thing with aging that I oftentimes see is people start developing more dysreflexia. The dysreflexia can be complicated by multiple factors, including the bowel. So it's not just one thing that sets somebody off. It may be a little bit of back arthritis, a little bit of bowel, a little bit of bladder, a little bit of shoulder pain. And so trying to optimize those things can help decrease the dysreflexia. But then looking to our GI specialist to help us with, hey, do they have a little bit of irritable bowel syndrome here? Are they having gas pain? Looking at something like Linzess, which can really lubricate things.
That's what I started on.
So there's lots of different options, but yeah, just as Dr. Rodriguez says, it's a very individualized approach. So the best method is going into the clinic, figuring out what works for you with all that experience.
Understood. Thank
Right.
you.
And I see that Darius has his hand raised, but I'd like to get through a little bit more with Carl and Matt giving other tips and tricks that they learned in going through this. So, Carl, you had mentioned that you've learned how to manage things, that you track things regularly.
Yeah, I mean, the big thing with me was just really trying to understand everything that's going on and how it affects me. So I started out with just a chart, from 24, the hours from 12 hour, 24 hour, not so much the 24-hour part because I'm sleeping mostly 8 hours a night. But for the most part, while I'm awake, just keeping the track of when I eat, what I'm eating, when I have a movement, what medicines I'm taking, and just looking at what that graphs out to be. So I'm trying to learn how to control this better because I still can't get to our target, but it is improving, and I do understand a little bit better. I know I don't understand why, but like when I go hypoglycemic, when my blood sugar drops low, uh, and I take a few carbs to bring it back up, then I completely lose my appetite for a couple of hours, at least 2 to 3 hours, maybe more. So I may not eat. And then on the other hand, when it goes over 200, I get a tremendous sense of hunger, wanting to eat. And it's, even though it's trending down, I still feel that hunger. So I'm just trying to get a handle on it and why that's happening, and And like you said, Dr. Ruiz, we will discuss this later on, but I'm taking notes now so that I can present you with my ton of questions.
Absolutely.
But I guess one of the questions embedded in there is it better to have specific meals or to eat smaller amounts over more frequently? Does that impact?
Smaller,
Um,
more frequently is what I see.
okay.
Gives you a little bit more consistency. And I don't know necessarily why, but if I eat consistently at certain times of day, smaller amounts, not necessarily getting terribly hungry or letting my blood sugar get too high or too low, seems to keep things on track better.
There is something that I wanted to say too. I think everyday regular bowel medications don't necessarily work well if you're backed up.
Yeah.
So with that said, if you haven't had a bowel movement in a week, we need to do something more, so escalated. So you'll need a clean out. So essentially, like, you need to drain all yourself out and flush yourself out with increasing either the regimen that you're on or taking, either magnesium citrate to clean out or go lightly. Or, increase doses of Miralax just to flush out. Because again, whatever you're trying to do with your bowel regimen, if you're trying to do it with the everyday medications, it will not work. You will not come up with a good combination and strategy if you're backed up.
Anything to add to that, John?
Yeah, I mean, very similar philosophy. I think that, yeah, if you're backed up, clean out is definitely indicated because those medications won't work. My typical clean out is mag citrate, and then 4 hours later do an enema, like a Fleet's enema or a soap suds enema, whatever you kind of have available. If you don't have a good movement in 4 hours, then you can do it again, whether that's the next day or 4 hours later is fine. People with renal disease, things like that, mag citrate may be contraindicated. And so again, individualized decision should be prescribed by your physician.
With mag citrate, you have to like get extra hydrated after you take it. And don't you have to get like electrolytes and stuff back, like from Gatorade, stuff like that with mag citrate?
Well, if you're cleaning yourself out to the point where you're,
I've been
more
there,
than, yes, but, it depends too on how backed up you are. So, your cleanup will be more aggressive if you're more backed up. So if you haven't pooped in like 2 weeks, obviously you need more aggressive cleanouts, versus if you just haven't pooped in, 3 or 4 days.
And if you're not,
And when you're more aggressive, then that's when you have to hydrate.
and if you're not having gas, that's a sign that you may need to go to the hospital.
Correct.
And Matt, I know one of the things you had mentioned that was helpful for you was having people to talk to, whether during rehab or during a longer stay at the VA. How did that help?
That helped a lot. I mean, just, how do I do this kind of thing? There was a lot of people my level of injury there that were into sports and I just connected with really well. And I don't know, they were like in the same predicament I was with the bowel program. Typically it was hemorrhoids basically. I was getting the hemorrhoid surgery like a haircut until I think just the being able to my bowels being active, I guess, plus losing muscle tone in my abdomen, it just seemed like they all said about 20 years, and here I am 20 years. But having them when I was first injured to kind of show me the ropes, it was very important for sure.
And I think normalizing the process that, this is just something you do, that
Well,
your
and
body
that,
needs to work differently.
that's one of the things that really kept me back from getting the colostomy was, oh great, I'm strapping a bag of shit on me, basically, is what would go through my head, and kind of getting over that stigma. And I guess it was just oh, great, I don't want to be abnormal, one more thing kind of stuff. Plus, you know, Darius, like you said, you get to the point where it's just frustrating. I've been in tears sometimes because I haven't been able to go somewhere. And I definitely look into it, getting it.
Is there anything else you would recommend for folks, or you think folks should consider?
Well, I was hoping to sneak in a question. uh, with my level of injury and the colostomy, I thought it was crazy how many hernias or how common hernias were. That's what I'm dealing with right now with an abdominal binder. And what I'm getting is it absolutely feels like at my transverse colon, I'm getting stool built up there. And what I've been doing is just trying to massage my abdomen, but I'm also keeping in mind I don't want to massage it too hard because of my being susceptible to hernias. How frequently do you see people getting hernias after they get this? Mine was peristomal, so it was around the stoma area. But does that make me susceptible in other areas for hernias to develop?
No, the most common is
Just
peristomal,
right around the stoma.
definitely. Yeah, particularly for those who, have decreased muscle strength, in the abdominal area.
Tone.
Yeah, so there's no tone, right? And because there's no tone, the things just tend to be more lax. And so I was actually going to mention that. I mean, obviously, colostomy is, great in one way, but there are also problems that do occur. And, for those considering, they have to keep that in mind. And so, using the abdominal binder and things like that is going to be helpful for sure, particularly post-operative. In the acute phase for about a year is important. And then trying to maintain weight is going to be important as well, and not get too big, because then that's what also causes hernias.
Well, I actually went through a period
And-
where I didn't eat. Could that really affect getting
Mm-mm.
constipated and then triggering AD more combined with the age and everything else?
So you can still get, constipated even with a colostomy. You can get constipated, so you will still need to
Yeah.
maintain the goal of that motility of having things go through your colon altogether.
Okay. And with that, what I'd like to do is ask our panelists to say one final thought, so that we can officially close up, and then we'll take the couple of extra questions for folks who are able to stay on. So let me start with Carl. Any additional thoughts, Carl, for folks that you would like to share about what you've learned or?
Yeah, just be open. Don't be afraid to talk about it. Don't feel shame about it. It's just something you have to do. Try to track it. Try to keep track of what's going on, paying attention to what you're doing. Those are the things that I would suggest are really important.
Thank you. Matt, any final
And
thoughts?
I guess we're directing this to Darius. My man, I'd go with it and get it done. I think it like you said, being more independent for you, being a quad, and especially with the wound, I think it's do it or talk with your doctor about it.
Okay. John, what would be general thoughts about neurogenic bowel and bowel management?
Yeah, so I think it's trial and error at first, and figure out what works for you, and talk with your physician, become educated on the different medications, how each one affects you, and also try and get a regular schedule. Your body creates kind of a timeline for these things to happen, and if you do it the same time of day, every day or every other day, it's going to go a lot better than trying to move things around. And yeah, it's more of an art than a science. There's lots of factors that go into it. And that's why you want to be empowered to maybe skip a Miralax one day if things are a little loose after a burrito.
Okay, thank you. And Dr. Rodriguez?
mute.
So don't be discouraged if one medication or the other is not working. It might just mean that you need a combination of different medications. And as you can see, I presented a whole list. You know, if we need to go to the next level, then, you know, we can go to the next level. And then allowing your body to sort of like respond to the medications adequately will be important as well. And then making sure that you empty. So like I said, it's two components, motility and emptying. So, you know, the emptying is very important. So the more regular emptying there is, the better the motility is as well. So, yeah, I know it's challenging, but if you're able to stick to a schedule, make it as consistent and regular as possible, as adequate as possible, people have better quality of life and, you know, have better sense of health and well-being, and avoid the hospital altogether.
There we go. I want to
I just wanted to say one more thing. I did do the Parastine thing prior to doing the bowels, and that worked for me for about a year, but it I think it was just age, no muscle tone, you know, years since injury, all that. But I did have success with that, so that if Darius wanted to look into that, I'd definitely recommend looking into it.
And I want to thank all of you. I think what we're hearing is that it is individualized, that you find a good provider, you develop a relationship, and then you figure out the best way to communicate with them, because it's a partnership, and you bring the expertise and the data about your body and what works, and they bring in the current best practices. And so I'd like, once again, like to thank our panelists for being here. I'd like to thank all of you for joining us. Remind you that we will have this available online in a few weeks. Remind you to complete your evaluations. And once again, thank the Michigan Spinal Cord Injury Model Systems for presenting this. And finally, invite those who would like to have a few more questions and would like to stick around for a little bit, but we'll let our ASL interpreters sign off, because I know we've kept them for a little while longer. So thank you all once again for being a part of this important conversation. Darius, I'll let you go and talk a little, ask your question again, and see if there are any other questions that have come up.
Yes, before I proceed with my final few questions, allow me to thank you all for this very, very informative forum today. I'm a registered nurse myself for 30 years, and I did telephonic triage nursing for 17 years post-injury, and that's why I got the wounds, because of sitting so long doing telephonic triage. Now, it's great because now it's multidisciplinary. We have doctors specialized in the field, and we also have spinal cord injury patients who are like me. So it takes one to know one. So that's very helpful. Now allow me to ask a few more questions. First one is there a colostomy which is bagless or no bag at all, by which you just open that area and, you know, irrigate it and it comes out, or all colostomies always have bags? Number two, what is the turnover time for a colostomy to normally heal? Like, does it take 3 months, 6 months for the stoma to go to its normal size? And my final request is, Dr. Rodriguez mentioned earlier about a list of medications that may affect the timing of which, if they're taken around this time and with certain medications, would cause more problems, and it's better to take them around this time, at the time of the day, and not with these medications, and if there's a list for that. Sorry, that's a long list of questions, but thank you again so much.
Sure. You want to answer the first two questions, John? You're on mute.
All right, so the first one was, is there a type of colostomy with no bag? No, I'm not aware of a colostomy with no bag. There are different varieties of colostomies or bags. There's one that comes from the small intestine as well. And then there's also a invasive bowel procedure called the MACE, which is an anterior grade continence enema. And basically they take your appendix and you're able to flush your colon forward. It's typically
Wow.
done more in pediatrics, but sometimes it will be done in adults. And then in terms of the stoma and maturation, typically we see people with functioning colostomies after the first few weeks in terms of healing. And they look pretty similar to the way that they're going to look for the rest of their lives.
So the third question, Darius, what was that again?
Meds.
The list of
Oh.
medications, doctor, you mentioned earlier.
Oh, so
Uh-huh.
I typically, so, you know, like I said, I promote like regularity, consistency, time of day, so that your body is habituated to, you know, emptying. So for example, someone chooses nighttime to do their bowel emptying. You know, I recommend that people take their meds at least 6 to 8 hours prior. So I would have them take it at noontime or earlier, so that, you know, so the whole thought is to get most of the stool that needs to be evacuated for that time being moved to the rectal area, so that by the time you do your bowel care, you know, it's there. So meaning it's ready for emptying. You allow the medications to, you know, push things through as appropriately and adequately as possible. So that's for nighttime. And if you're wanting to do it in the morning, then you take it at bedtime to allow the meds again to work. And I, you know, again, it's preference, but I typically have folks take all their meds at one time and not at separate times. I never say twice a day. I never, or I wouldn't say never. I try not to say twice a day. I just say, okay, if you need, you know, 3 doses of Miralax, then you take it all at noon. To me, it's, at least from my experience, it's most effective that way, because you consolidate the, you know, the meds to one time. And I tell my patients, think about, you know, the meds being like little people pushing, you know, pushing the stool through your colon. The more you have, you know, the more people you have pushing the stool, the better at one time, rather than, oh, having just 2 pushing at one time and 2 pushing at another time. Consolidating the meds to just like one time to achieve the movement of stool to the rectum, for me, seems to work best. And then you avoid the issues with incontinence as well, because, you know, you push a little bit, you know, that for me increases your episodes of incontinence or unwanted, unplanned stool.
Yeah, so a common mistake I see is when people are taking their Senna in the morning and they're doing their bowel program in the morning, because the Senna takes like 6 to 12 hours to act. The oral bicicotal is the same way. It takes about 6 to 12 hours to act, and that it's all individualized. Some people respond to it quicker. For suppositories, a common mistake that I see is that people won't do a suppository early enough. They'll do it like right when I'm doing my bowel program, even though it needs to cook for 30 to 45 minutes. And NMEs is more like 15 minutes. A magic bullet might be more on the 30-minute mark because it's a little bit more powerful than a regular suppository. The other meds like Milk of Mag, it takes probably about 4 hours-ish. But I mean, that can be a lot longer if people are constipated. Lactulose, I find, acts a little bit quicker than the Senna. It probably takes about 4 hours-ish, sometimes even faster, to push things through. Mag citrate, again, about 4 hours-ish. But yeah, again, all individualized and different responses for different people.
And
Thank
final follow-up question. Yeah, sorry. Yeah. Aside from the scheduling of laxatives, because I do my bowel programs Mondays, Wednesdays, and Fridays in the morning, so it's regular. Aside from the laxatives, I also have opiates, anticholinergics, antispasmodics, supplements, or so. Is there a specific timing or a better timing if I do my bowel programs on the mornings, Mondays, Fridays, and Wednesdays? Do I take them at a certain time better in terms of time proximity to the bowel program? Or
So typically, like if you're doing it in the morning, the night before will be
Okay.
helpful.
all
Yeah.
right. Thank you
Good.
so much. That's
Thank you.
thank you also, Carl, and thank you also, Matt. And you've been also helpful, and Michelle.
Sure. And we have a couple other folks who stayed on the line. So if you have any questions, feel free to raise your hand and we will ask our physicians here to answer them. Otherwise, we will allow folks to sign off.
Is Darius still there?
He's still there, yes.
Okay, hey Darius, one thing that you might want to look into, after the colostomy, I did irrigation. And a lot of the, you know, you learn everything on YouTube. When it worked well for me prior to the hernia, it worked out great. And a lot of people say that you can go between irrigation sessions without wearing a bag. At least that's what a couple people said. And it might look something he might want to look into. But when it was working for me every other day in the morning, and as far as meds, I don't think it's necessarily when you take them, just take them at the same time, get on a schedule.
Noted, and
Sounds
will do.
also like knowing what the time frame, what the half-life is, when they're likely to work. And
Right,
so-
or just basically getting on a schedule, and then once you're on
I
the
think it's
schedule,
less
you're-
of an issue with a colostomy though, like, you know, in terms of timing of meds. But for those who don't have a colostomy, you know, it's critical that, you know, they time the meds so that they don't have unexpected, you know, stool occurrences or issues with fecal incontinence.
Right. Hey, thank you, everyone. I greatly
guys.
appreciate your being here. I mean, how often do folks get to really ask the experts about their experience, their advice, what best practices are outside of rehabilitation itself? And so this information, I think, is incredibly important. So thank you both, and have
Yeah,
a good week.
I appreciate your help. Thanks, Doc.
Thank you all. Thank you.
Thank you.
Thank you
all,
for
and
having
blessings
us.
and more
It's been our
power.
pleasure as well. Yeah,
Uh,
it's been our pleasure. Thank you for having us tonight. You know, again, you know, it's nice to educate everyone, so pass it along.
That's what I say. I mean, if it'll help out the next guy, that's my whole thing for motivating behind doing this.
And also go visit the Michigan Model Systems and the Knowledge Translation Center
That's right.
for the model systems. They have a lot of good information on all of this. And some of those lists that you were asking for, Darius, they're on there. So that's a reliable resource.
Learning is from womb to tomb, indeed. So thank you again. I will do so.
Absolutely.
Take
Thanks.
care,
All right.
Darius.
Take
Have a
Thank you,
good night.
everybody.
Happy holidays, guys. Thank you.
Happy holidays.